Good evening to everybody that's out there in the internet. I'm Anne Coffey. I'm a fertility specialist located in Cairns. This evening I'm going to give you a pretty broad overview of quite a number of fertility topics. Our little clinic here located in Cairns, there's two specialists. There's myself and Dr. Natalie Kesey-Coulding. We've got a lovely team here. We offer a full range of service for people with fertility issues. We have a big natural fertility service, and also we provide a whole range of assisted reproductive options, including IVF. So tonight I'm going to talk about a whole range of topics. I'm going to start with talking about the science of conceiving. I think it's a really useful thing to understand when you're trying. I'm going to talk about lifestyle factors and how they impact on people's fertility. I'm going to talk also about fertility testing. What are the standard tests that we do and why? I'm going to cover a couple of very specific fertility conditions, including some very specific conditions, just very briefly for you. And then I'm going to talk also about fertility treatment options and provide an overview of those as well. So let's get started. At the end, there is you're able to ask questions. So I'm more than happy to answer any questions, anything I haven't covered this evening. So ask away. All right, I'm just going to get these slides moving. So on this first slide, so we're just going to go through the basic science. It feels a bit like a school science lesson, but I think it's really useful knowledge to have in this situation about how conception occurs. And it's a pretty remarkable, pretty amazing process. So if we start right at the start, after intercourse, there's sperm that's sitting in the upper vagina. And then what happens is the fastest swimming sperm travel up through the neck of the womb into the endometrial cell layer. This is sometimes called the lining. You'll see with this education picture that we're using here that it shows the uterus as an open structure, but in fact it's actually closed all the time. This is just the way it's represented in education. So there's these two very thick layers of cells, and sperm have to transit through these. It's a pretty difficult and treacherous journey that sperm need to make it out to an egg. So if they can make it through this lining, then it needs to turn the corner and make its way into the fallopian tube where it swims against a current. The fallopian tube is the site where fertilization takes place. And what the sperm needs to be able to do is make its way all the way out to the other end. It's drawn out there by chemical attractants that are released by the follicle containing the egg. And at this point, this is where it can pool and sit for a number of days waiting for the egg to be released. The journey is so difficult for sperm that only 1 in 14 million make their way all the way out to the other end, which is really quite remarkable. Now, eggs are released from the ovary, from a little follicle that grows in each cycle. Once the egg is released at ovulation, it's swept up by the fingers at the end of the fallopian tube, where it will hopefully come into contact with sperm that's been sitting there ready and waiting for the egg. The sperm crowd around the egg and compete with each other so that one can eventually break through the outer cell layer that's around the egg and make its way into the egg and achieve fertilization. In fact, one of them, when it does make it through, is able to induce an electrical current around the egg that knocks out the other sperm. So it's a pretty incredible step, the step of fertilization. After fertilization, the embryo has 5 days of development that it takes place within the fallopian tube. And this makes the fallopian tube an incredibly important structure in human conception because it's the site at which early embryo development takes place, and it has to transport that embryo and provide it with the right nutrition as it's transported back to the womb. So that's pretty incredible stuff. The embryo undergoes cell divisions throughout these days, and after about 5 to 6 days, it forms a complex embryo called a blastocyst. And blastocysts are an embryo that has an outer cell lining, an inner cell mass, and a fluid cavity. After the blastocyst makes its way back to the womb, it then has to begin the incredible process of implantation. And this alone is quite remarkable. And this is a process of adhesion between the embryo and the endometrial cells, the lining, and eventual invasion of that embryo into the deeper layers of the uterus, in which a connecting circulation is formed to support a pregnancy. So these are all the remarkable things that need to happen to achieve a pregnancy. The next slide is showing how we understand when the best time to try is when you're trying to conceive. Now, most of you are probably using fertility apps. That's a really common thing that people will use to track cycles, and a really useful tool at recording cycles, at providing education, and in some people in providing good timing, advice around timing. So they use a fairly simple principle. So if we look at this circular diagram here, this represents the cycle in somebody that's got a normal monthly or 28-day menstrual cycle. The cycle begins with the first day of bleeding. Oh, sorry, I'm just going to make sure I've got this screen up. Excuse me, got a slight problem with my issue here. Sorry, I'm just going to get this screen up for you. Okay, sorry. So I'm just going to go back to the diagram, sorry, that I was speaking to, now that I've got it up there for you. So this circular diagram shows how we represent the cycle. Day one being the first day of bleeding in the cycle. We count the first day. We're not really interested at the end of bleeding. It's the first day that allows us to establish the beginning of a cycle. On average, in a 28-day cycle, women will ovulate around day 14. We therefore say that the best days to try to conceive are, in fact, the 2 to 3 days leading up to ovulation. And this goes back to the things I've just been talking about in terms of what it takes to make a baby, in that the sperm can actually sit there ready and waiting and alive. It's a strange idea, but true, waiting in the fallopian tube for the egg to be released, whereas the egg's life is actually quite short. It's only about 12 to 24 hours. So the ideal situation is that you have sperm there ready and waiting for the egg to be released so that it can crowd around and achieve fertilization. So this is a pretty easy concept to work with if you have a nice regular monthly cycle. Trying really between days 10 and 14 on average will give people the best opportunity for pregnancy. But if your cycle is more variable or longer, then things are going to be much more difficult. And apps can be helpful, but if the cycle's very irregular, this is where apps don't always help out. There's a very simple principle behind how you can understand your cycle if it is a bit longer, and that is that the time from ovulation to the period is the fixed part of the cycle, and that's on average about 14 days in length. So if you have a cycle that's regular and longer, say a 35-day cycle, that means on average that person's going to ovulate around day 21 of their cycle. So it's just the length of the cycle minus 14. If the cycle, though, is very irregular, it can be much, much harder then for you to work out your best time. And we do ovulation tracking in our service, and I'll talk about that in a minute. And that can sometimes be a really useful way of getting a better sense of when the best time is to try to conceive. So I'm going to move to the next slide. So I'm going to talk next about lifestyle factors and how they impact on fertility. I've got a whole list of things here, and I'm going to start with the difficult issue of age. And so I meet people all the time, I meet women all the time that are really confused and nervous around how their age impacts on their fertility, because we get all sorts of confusing information in the community about what age means for us. Now, the first thing to understand is that male and female reproductive biology is really, really different. For women, we are born with all of the eggs that we'll ever have, and we have the most eggs we'll ever have when we're inside our mother's womb. And we spend our lives losing them. We haven't got any capacity to make new eggs during our life, and we can't repair eggs when they become abnormal. Our fertility obviously declines also across that time frame. So we tend to have reasonably good egg numbers and egg quality during our 20s. This starts to change in our late 20s. It accelerates much more in our late 30s. When we're 25, about a third of all of the eggs that are released cycle to cycle in 25-year-old women are actually abnormal. Human reproduction is actually a pretty inefficient process in many ways, but by the time we're 44, it's about 90% of eggs that are abnormal. So we have both a loss of quantity and quality across our lifetime. This does not mean that people can't get pregnant. Of course, natural pregnancies occur right throughout the 30s and into the 40s. But if there are additional fertility factors, that's when things get a whole lot more complicated. It's important, though, that people get specific advice about how age is impacting on their fertility individually, and we can make measurements of egg numbers. It's much harder to assess egg quality, but there are tests that we can do, such as a blood test called AMH, which is able to assess the remaining number of eggs that people have. Male reproductive biology is quite different, though. So in the terms of men, they can make hundreds of millions of new sperm every day. So this is really different to what happens in women. And men don't experience the same sort of end point in fertility that we do, although there are age-related effects on male fertility. So there is a reduction in cycle-to-cycle fertility rates in men once they're over the age of 40 to 45. And we do also see some increase in miscarriage rates, as well as increases in new genetic disorders that can occur in older men that are having children. So again, these are things that we can provide really specific advice around. The next thing I have on my list here is smoking. And smoking, I guess I see really as a bit of a non-option when it comes to fertility. It has such a toxic effect on both male and female fertility. Smoking in women in particular is directly damaging to eggs. So it accelerates the rate that we lose our eggs, but it also directly damages the DNA and the energy production capacity of eggs as well. So we always strongly encourage that women don't smoke at all when trying to conceive, and that this is something that stops as soon as possible. With men, what smoking does is it's able to, in some men, affect the production of sperm, so both number and swimming capacity of sperm, but it can also do some hidden damage. So it can also damage inside the sperm head, the DNA itself, things that we don't see on standard testing. The next thing on my list I have here is weight, which is always a really tough and tricky issue when it comes to fertility. We know that weight, if it's being overweight or obese, in addition to fertility problems, can complicate things further. It can probably impact largely on implantation, but maybe on some other factors in the whole process of fertility. There are fertility-specific conditions that we look after that are very much linked to weight, such as polycystic ovarian syndrome, which I'll talk about a little bit later. And actually managing weight and reducing weight in this condition can improve fertility dramatically and improve ovulation as well. It's a really tough issue, and so it's one that requires a lot of supportive care, which we can provide if people are needing to lose weight whilst they're dealing with the difficult issue of infertility. The next thing I have on the list is alcohol. So it's a complicated relationship, alcohol and fertility. There is some evidence to show that for both men and women, drinking more than 5 standard drinks a week can be associated with fertility issues on both sides. It also, drinking at this rate in women does increase the risk of miscarriage as well. And so I guess we'd recommend that people consider, if they're drinking more than this, trying to work towards reduction. There are some men that have very specific effects from alcohol on sperm production. It can have a big impact on sperm swimming and sperm numbers in those men, and also probably produces some of those hidden issues in DNA that we don't see on standard sperm testing. So it's all about moderation. It's not about necessarily being completely abstinent, but moderating that intake during the preconception time. Next on the list, I have diet, and I'm sure any of you that are out there reading on the internet or connected to social media would be aware that there's so much information that we're bombarded with about what to eat, what not to eat these days, and it's sometimes presented as the magic cure-all for many issues. If we talk about fertility very specifically, we can say that there's some evidence that a Mediterranean style of eating is beneficial for fertility. So Mediterranean style eating is really a diet that doesn't include a lot of processed foods. It's generally whole foods, including green leafy vegetables, things like tomatoes, olive oil, fish, sort of anti-inflammatory type foods. And there appears to be some benefit for this style of eating if people are changing from a poorer diet for both male and female fertility. And finally, I have on the list here stress. And I've included this because it is such an important discussion. It's a regular discussion I have with people every week when I'm meeting them. There's a really persistent perception in the community that stress causes infertility. as an independent issue. So the first thing I can say there is that there's no evidence that stress on its own is the cause entirely of the infertility of any couple. Stress can impact on things that can relate to someone's fertility. So somebody that's very stressed might take up smoking again, they might drink more, they might put on weight, and couples under a lot of stress might even have less intercourse. So of course it can impact on things that are meaningful to fertility, but as an independent isolated cause, there's simply no evidence to support that. The reason it's important to talk about that is because when you get that advice, whether it's from family or friends, you know, be less stressed, don't think about it. The problem with that advice, even when it's really well meant, is that it creates a sense of blame, that it's like, well, if you were just less stressed, this would happen. And, you know, I wish it was that simple, but of course we deal with a lot of medical infertility and more complex issues that are not going to be addressed purely by managing stress. It's important to manage stress during this time in your life though, because obviously, you know, it's important for well-being, it's important for people that are going to be future parents as well. So we look really hard at managing that with the people we care for, but making sure we're clear about the fact that it's not the one and only cause of infertility. All right, so I'm going to move to the next slide. So I'm going to talk now about fertility testing. Now I realised I didn't have my nice picture up earlier when I was discussing conception. So this picture here just allows me to sort of explain what it is we actually do test for when we do an evaluation of a couple. So we need to look, when we're testing, we need to look structurally at the uterus and lining. We need to look structurally at the ovaries and make sure they're healthy and the tissues around them. And that's very simply done just with a pelvic ultrasound. We also need to confirm that ovulation is happening. I'll talk about that in a minute. We need to check and make sure the tubes are open. I'll talk about how we do tube testing. We also are going to check for hormones that relate to the normal menstrual cycle, things like thyroid and prolactin. These can be done with a simple blood test. And we also can measure the total number of eggs that are remaining. So understanding this egg reserve, especially if there are age questions that we're dealing with. And the commonest way we do that is with a blood test called AMH. We also, when we're doing a standard evaluation in the woman, we'll do a range of infectious disease screens for infections that are relevant to pregnancy. So that's a standard set of preconception bloods. And for the man, of course, we'll do a semen analysis. So ovulation testing. So many of you are probably testing or monitoring ovulation in some way at home. So that's obviously done in many, many ways, done with temperature monitoring, urine sticks and so on. And these techniques can be very helpful. Obviously, we do see some people, though, where they're having difficulty monitoring ovulation or their cycles are very irregular or prolonged. And so we have an ovulation monitoring service. So that's an ultrasound service where we can monitor and check the best time in the month to conceive. It's a good place in which to confirm ovulation, but also check ovulation in subsequent cycles if that's going to be of benefit to people. Because on ultrasound, we're able to see very clearly the events of ovulation. We're able to estimate and be quite clear about when the best time to try is, so that window before ovulation that I've talked about, and that's a very useful tool. So that's something that we can provide. Testing the tubes can be done in a number of ways, but the most standard test that we do is something called a hycosi, and this is an ultrasound test. And basically the point here is that a normal ultrasound just won't show you the fallopian tubes. They're a really soft structure. And they're very similar to the bowel that surrounds them. So the only way we can see them normally is if we pass some dye through them. With the ultrasound test, the hycosi test, a little catheter is placed inside the neck of the womb, and a bubbly mixture of sugar and saline mixture, so just with bubbles in it, is gently injected, and we can see the little bubbles as they travel through the fallopian tube. So that can just confirm that it's open, and we can see the dye spilling out to the other side. There are other tests, and there is a more complex test of fallopian tubes which involves a keyhole operation, and that can be considered, that's considered in only a small number of people, but where there's a suspicion of significant tubal issues, that can be done. But usually the ultrasound test is sufficient. Semen analysis is a pretty simple and straightforward test. In most couples that we see, this is the main thing that the man will need to do for testing primarily. Basically, it's analysing under the microscope a single sample of sperm and looking to see how many normal-looking, healthy, fast swimmers there are. We want to estimate are there enough that can make that 1 in 14 million trip out to the other end of the fallopian tube and successfully fertilise an egg? So the things that are looked at by the scientists are the total number of sperm, the number of fast swimmers, and the number that look normal. When you make tens to hundreds of millions of something a day, there's a lot of mistakes that are made. So in fact, there's a lot of sperm that look abnormal in a normal analysis, sperm with 2 heads, 2 tails, some really interesting forms. But what we're estimating in that test is that number of normal fast swimmers that are present. It's a basic and crude test, and male semen parameters are different all the time. So if we ever do see abnormalities, it's always really important that we repeat them, because it may not reflect a persistent problem. It may just be a sample that reflected a problem at the time that that sperm was made. Sperm production takes 100 days. So when we do a test, we're really just getting a snapshot of what was going on over 3 months ago. So if we do see abnormalities, the advice is always let's repeat and see if there's a persistent pattern and understand how it might relate to fertility. So the next couple of things I'm going to talk about are a couple of very specific fertility conditions. And the first one is endometriosis. Now, I meet women all the time who are worried about this diagnosis, may have been told they have this diagnosis incorrectly, and it can create a lot of fear around what it means for their fertility. So what endometriosis is an inflammatory disease where implants of abnormal tissue grow outside the womb. So the most common site that we see it is on the peritoneal surfaces, so the shiny surfaces that line the pelvis. And these little implants are made up of the endometrial type cells that line the womb. And these can cause pain in relation to the cycle, pain in particular at the time of periods. And they have a whole range of potential effects on fertility. It's important to understand that the only way you can diagnose endometriosis is via a surgery. So it generally cannot be seen on ultrasound. The smaller deposits that line the pelvis simply cannot be seen on ultrasound. And so the only way it can be formally made is if a keyhole surgery is done, if the endometriosis is identified and some is biopsied and sent to the laboratory. Endometriosis classically causes period pain. It can cause pain at other times in the cycle, and it can cause pain with intercourse. The important thing to know, though, is that it doesn't always cause a major fertility issue. There are certainly some women with the condition that go on to have their families very normally, but then there are also women with endometriosis that can have much more complex fertility issues. So if you're concerned about the symptoms of endometriosis, then it's really worthwhile talking to a fertility specialist or an endometriosis surgeon about these questions and getting specific advice about whether diagnosis is warranted. The next condition I'm going to talk about is another condition that I see really commonly. And again, I see people that feel confused about whether they have the diagnosis or not, and often very frightened about how it's going to impact on their fertility, and sometimes believe that it means they'll have to have complex treatments like IVF, which simply isn't true. So PCOS is a fairly complex condition to diagnose. The diagnostic criteria we use in Australia is that you have to have 2 out of 3 of irregular periods, evidence of high testosterone in the blood, or ovaries that look polycystic. And what we mean by that is ovaries that are quite large and contain many, many of these little bubbles called antral follicles. Now, people worry that these are cysts, the way that we think about the sorts of cysts that can sometimes that grow in the ovary. But these little bubbles that we see on ultrasound, these are actually quite important, especially in people that are trying to have their family, because they're a normal structure and they reflect the fact that somebody has good egg reserve if they have good numbers of these bubbles. In polycystic ovarian syndrome, however, there tends to be an excess of these. But as I've said, the criteria are more complicated and it needs to be more than what is just seen on ultrasound. Typically, when I see this condition, I see people that are having irregular, infrequent periods, sometimes no periods at all. But PCOS is a condition that responds in a lot of people really well to lifestyle changes. Weight loss in particular can make a huge difference to cycles and can normalise cycles enough for certainly a good proportion of people to get pregnant. Or we can sometimes use really simple tablet treatments to try and normalise the cycles. It does not always mean that people need very complex fertility treatments, but it is obviously important that the diagnosis is given correctly. And the last condition I have here is unexplained infertility. And this is a condition I see really commonly, and it's a really difficult one for people to experience, because if you're going to go through something as difficult as infertility, it's often obviously pretty challenging if you can't be told exactly why somebody's not conceiving. So unexplained infertility is a diagnosis that we make where we have a couple with infertility, where we've been able to show that the tubes are normal and open, that the sperm production is normal, that ovulation is happening, and that all other standard testing that we've done appears to be normal. So that's unexplained infertility. Now, what's really important there is that that does not mean that there is no reason. What it means is that the reason or the reasons that the couple are not conceiving are hidden away from the standard testing that we do. So if we keep in mind what the testing tells us, it tells us structurally what the womb and lining look like. It tells us that the tube's open. It tells us that sperm production appears to be sufficient. It tells us that ovulation appears to be happening and that the related hormones are doing the right job. But it doesn't actually tell us about egg quality. We have no means to measure egg quality in standard fertility testing. It doesn't tell us that the sperm and egg are actually successfully fertilizing when attempts at conception are actually happening. It doesn't tell us anything about that embryo quality in terms of the embryos, how they're developing, their quality of development. And it doesn't tell us that the tube is doing its job entirely, because the simple tests we do simply show that the tubes are open, but not showing us those really critical functions that the tube has in transporting and nurturing the embryo as it grows. And certainly we don't have any tests, unfortunately, of the process of implantation. So unexplained infertility tends to be hidden away from the testing that we do. What I always tell couples with this condition, though, is that they should never lose hope for a natural conception. Just because it's taken longer and just because we can't find a cause does not mean that they cannot conceive. And so we do work very hard with these couples on helping them conceive naturally where possible, but obviously looking at more complex treatments if they're required down the track. All right. So I'm going to talk finally about, I'm going to give an overview of all of the treatment options that we would consider in a fertility clinic. So let's just start with the simple treatments, because of course this is the where we want to start and where we'd like to help as many people as possible is with more simple interventions. So as I said, we do cycle monitoring in our service, and this can be really useful in lots of contexts, certainly at the time of assessment, certainly when dealing with irregular cycles, sometimes dealing with tricky issues such as partners that work away. And we do that, as I said, with ultrasound and sometimes with blood tests. We can often do that when we're looking at managing lifestyle issues such as weight loss and dietary improvements, and that can certainly assist a good proportion of people. Next treatment that we consider are medical treatments such as ovulation induction. So in most cases, this will be a tablet treatment. And in most cases, this is dealing with conditions like PCOS, where somebody's presenting with prolonged and irregular cycles. And we can use tablets such as a diabetes medication called metformin to help regulate the cycle. And we can also use a medication called letrozole, which can help bring on ovulation. This is a tablet that's generally really well tolerated. It's taken just for 5 days at the start of the cycle, and then we can monitor ovulation in that cycle. Sometimes injections can be used also for inducing ovulation, but in general, this is a pretty uncommon treatment these days, and the tablet treatments tend to be quite effective. The next treatment to consider is IUI, or intrauterine insemination. So this is a pretty simple principle. This is where a washed and concentrated sample of sperm is injected into the upper womb, and it's done just before ovulation. So it's in a cycle where we've monitored ovulation using ultrasound and blood tests. We pick the best time for the sperm to go back, and then we simply inject it, very quick procedure, inject the sperm into the upper uterine cavity. There's lots of reasons why we may do IUIs. So common reasons would include when we're using donor sperm for conception. Sometimes we do it where we've got a partner that's working away, and we have that as a common issue up here, where we can freeze sperm and provide couples with opportunities to conceive if that's proving to be an issue. Sometimes in couples with sexual difficulties as well. And sometimes in younger couples with unexplained infertility, this can be discussed and considered. The final treatment I've got here is IVF, and this is of course quite a complex treatment, and what I'm going to give here is just a nuts and bolts overview of what IVF is. So what I've got here represented is a 28-day cycle, which most IVF sort of fits into that framework. So even though it's quite complex, it still fits into something that looks like a natural cycle. So an IVF cycle starts with a period, day 1. And then the first 2 weeks of the IVF cycle involve the woman giving herself injections or somebody providing injections that grow a batch of eggs. So the major difference between IVF and all the other treatment options I've mentioned is that most of those other options are working on producing that natural egg in a month, or the 1 egg in a month, and then all those parts of natural conception following. IVF is quite different because in an IVF cycle, we try to create a number of eggs in 1 month. That allows us to make a number of embryos, and that provides us with more opportunities to grow good quality embryos and more opportunities for pregnancy. So that's what the first 2 weeks is all about, stimulating the ovaries with a hormone injection called FSH each day to grow a batch of eggs. These injections are often a pretty daunting thing for somebody to consider, but they're usually pretty well tolerated by people as they travel through the treatment process. We monitor the response to the injections with ultrasounds, so ultrasounds throughout the process. And then after the 2 weeks, the eggs that we grow, which the eggs turn into, well, they're sitting inside larger bubbles that we can see and track through the cycle. So we remove the eggs from the ovaries by a very simple procedure, which is done under some sedation, under ultrasound guidance with a needle that passes through the upper vaginal skin into the ovary, and we simply remove or suck the fluid out of each of those bubbles. And the egg's then provided to our scientist. On the same day, if partner sperm is being used, then that's provided. If donor sperm is being used, then that's stored. And so all the eggs on the day of the egg collection are fertilised on that day. So we collect as many eggs as we've been able to grow. We fertilise all the eggs that we've been able to retrieve. And then what we do is we grow the eggs out for 5 to 6 days into embryos. And what we're doing is mimicking those stages I talked about before. So the 5 to 6 days that embryos grow inside the fallopian tube, we're doing that inside the laboratory. And then at the end of that time frame, we select the best out of all of the embryos, and then with a very gentle procedure that's not an operation, we place the best one gently back into the womb and then wait for pregnancy. We're able to freeze the excess embryos, and embryos do very, very well with freezing and thawing in this day and age. So we can, if needs be, we can use those frozen embryos for additional opportunities of pregnancy. So that's the nuts and bolts of IVF. So that was everything I was going to say tonight. So I was going to go to your questions if you have any at this stage. Let me just find them. Does anybody have any questions at all? No questions? Is there so there's a first question here. So is there a BMI limit for IVF? So we do have a guideline that we apply to, and that is our college, the College of Obstetricians and Gynecologists in Australia, has a guideline that recommends that we should not do IVF on somebody whose BMI exceeds 35. And this can be a bit of a difficult issue, but I guess what we do in that situation, when we're saying that we're using this cutoff, we're saying that, listen, having a BMI greater than that, we well understand that the success rate of IVF is lower in that context, and the risks related to all of those processes, such as stimulating the ovaries and retrieving eggs, are a bit higher. So we'd always work really hard on helping a person get down to that target, so that not only so that the IVF is safer, but it gives them the best chance of success. That's really important. The next question I've got is, what's the success rate or chance of conceiving on a cycle? Well, that's going to be very dependent on the reason that we're doing the treatment. So because we're talking about, I guess, when we're talking about IVF, then the success rate is very much shaped by the age of, in particular, the female age. So if we can transfer a good quality embryo for a woman aged under 38, then the chance of that making a pregnancy will be between 40 to 45%. But that number goes down quite a lot by the time somebody's 40. And then by the time somebody's 44 to 45, then success rates are very, very low. So the discussion of success rates is complex, and that has a lot to do with the fact that it depends on who we're treating and what the age is in relation to the embryos. But we do have success rate data on our website if you're wanting to have a look at that. The next question I've got is, how successful is treatment with an AMH of 2.8? That's a good question. It's a complex question. So I think one of the things to say about AMH, so AMH is that blood test I referred to before that measures the egg number, and an AMH of 2.8 is what we would call quite a low AMH. Now, AMH as a blood test alone is not a measure of the fertility of a couple. So if a couple has a low AMH, it does not mean that they cannot conceive. And in fact, people with lower AMHs appear to have the same average success rate for getting pregnant as people with a normal AMH age to age. However, there's other things we have to think about when we're thinking about a low AMH in IVF. IVF is, as I've said, a numbers treatment. It's a treatment where we try to grow a batch of eggs in a cycle. And if the AMH is quite low, it means that the number of eggs that we can make in the cycle will be much lower. And that can sometimes complicate IVF. It can also mean that it can be, in a person, harder to get a response to the injections, even if we give high doses. It really is going to, again, be dependent on age. So somebody with an AMH of 2.8 at 29 is going to have a different rate of success to somebody with an AMH of 2.8 at 41. So I'd always recommend with that sort of complex question that you get specific advice from a fertility specialist that's really tailored to your specific fertility. The next question I've got there is how to improve a low sperm count. That's a great question as well. So certainly all those lifestyle things I talked about before are really relevant. So we know and we see men being able to improve their sperm count by changing lifestyle factors such as losing the beer belly, because that can have quite a negative effect on sperm production, reducing alcohol intake right down or eliminating alcohol altogether, and stopping smoking. So certainly those lifestyle changes and improving general nutrition, we can see improvements in some men. On the other hand, I guess it's important to also understand that sometimes we're dealing with complex issues that were part of how the testes were made when that person was made, and are not always things that lifestyle factors will improve. And sometimes I meet men with very, very healthy lifestyles that have these abnormal sperm issues. We will, of course, in that setting, always do the testing that we can do for looking at other, looking at causes, the obvious causes. We do genetic testing and hormonal testing to try and understand it. And so in some people, we may not always be able to improve it, but certainly those lifestyle things can make a big difference and should always be pursued initially. If a low sperm count, though, is very persistent despite all of that, then often IVF with sperm injection, something called ICSI, is often the treatment that's used eventually if needs be. But again, that requires a really detailed conversation with a fertility specialist. Any other questions at all? No other questions? Well, thank you all for joining me tonight. Sorry about the slight technical issue at the beginning. Listen, if you have any other questions that you want addressed, obviously our clinic, we're more than happy to take phone calls if there are queries about appointments. Certainly you can get in touch with the clinic. And if you're wanting to come along and see one of us, your GP can make a referral. And I wish you all the best with your fertility, and thank you very much for joining us.